You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for June 6, 2025. This week, listener feedback on cardiac sarcoidosis, out-of-hospital cardiac arrest. Less is more, again, when it comes to post-stent antiplatelets, lipoprotein a, and atrial fibrillation and HFpEF. First up, some listener feedback. I received an email from Finland this week. Dr. Riina Kandonen from Helsinki writes that I should clarify some of my comments on the cardiac sarcoidosis paper that I covered last week. The paper I spoke about was from a primarily Dutch and Minnesota group, and they had compared professional societal recommendations for an ICD versus CMR phenotyping in patients with suspected cardiac sarcoidosis, and the key word there is suspected cardiac sarcoidosis. In that study that I covered last week in the European Heart Journal, CMR phenotyping by 4 criteria: no LGE normal EF, no LGE abnormal EF, pathology frequent LGE, and pathology rare LGE, performed better than professional societal recommendations for VT. Dr. Kandonen from Helsinki pointed me to an incredible circulation EPP paper from their group in Helsinki on 305 patients with either biopsy-proven cardiac sarcoid, which was just under half the group, or findings highly suggestive of cardiac sarcoidosis. Now, right away, this is a different population because the first study looked at patients with distant sarcoidosis, say in the lungs, and they were being evaluated for cardiac involvement, while the second study in the sarcoidosis this year studied patients with proven cardiac sarcoidosis. The two main points of differences arise. In patients with true cardiac sarcoid, all have pathology frequent LGE. So in the sarcoidosis paper, if everybody has pathology frequent LGE, it can't distinguish risk. Rather, the Finnish group showed that it was the degree and somewhat the distribution of LGE that predicts sudden death in VT. They found that myocardial LGE, making up more than 9.9% of LV mass, or affecting greater than 6 LV segments, may suggest prognostically significant LV involvement in a high risk of sudden cardiac death. This analysis and its implication bears similarities to what we do for hypertrophic cardiomyopathy, doesn't it? Namely, in HCM, there is a risk score that corresponds to a yearly risk of VT, and if that 5-year threshold reaches greater than 6% for sudden cardiac death, then an ICD is recommended. The ESC also recommends a similar type risk score prediction for laminopathies as well. ICDs for criteria above a risk threshold. The Finnish authors therefore suggested in their discussion section that their CMR findings could have clinical relevance. Quote, in patients who have no other guideline-based class 1 or 2A indications, implantation could be considered if LGE mass is greater than 9.9% by the full width at half maximum method, or the LG involves greater than 6 LV segments. They write less extensive LGE predicted a 5-year sudden cardiac death or VT rate less than 7%, with a sudden cardiac death risk of 0.6 per 100 patient years. And in these patients, other EP studies or close surveillance with repeated risk assessments could be discussed at shared decision-making. I think if you care about cardiac sarcoid and risk stratification, this is an excellent paper. It's worthy of a bookmark. And I appreciate the feedback because I learned a lot reading this extra paper and reading more about this. My one comment, and this is not at all a criticism of the paper or papers, but as a clinician, as a doctor, I struggle with these risk thresholds. Say in hypertrophic cardiomyopathy, what if the 5-year risk is 5%, not 6%? Or in the case of cardiac sarcoid, the LGE mass is 7%, not 9.9%. The dichotomization of ICD or no ICD based on continuous variables makes me nervous. It makes me nervous because we have a prevention of sudden cardiac death, and that's the ICD. But of course, I realize it would be unwise to place ICD in all patients, including these low-risk people, because of ICD harm. But not having an ICD and needing it is also a serious risk. I don't have the answer, and perhaps there never will be an answer to finding the ideal patient for an ICD. But hypertrophic cardiomyopathy and cardiac sarcoid are clearly different from the RCT-based heart failure ICD criteria. In heart failure, we have entry criteria from trials, albeit old trials, and it's sort of. Right? We used to be able to say that if you were like a MADE-IT2 patient, you would have a 30% lower mortality with an ICD compared to no ICD. That's from a trial. The modern problem, of course, is that medical therapy is a lot better, and that 30% benefit may be a lot less. And by the way, that is why that if you practice in Europe, you should be participating in the PROFIT trial of ICD versus no ICD in patients with ischemic cardiomyopathy. One practical comment from my experience is that if a patient with cardiac sarcoid has heart block and you're implanting hardware, it seems wise to strongly considering an ICD if the LGE is even close to any threshold that you're worried about. Once again, thanks for the listener feedback. I learned a ton from it. All right, next topic is news in out-of-hospital cardiac arrest. The AHA sent me 2 emails yesterday regarding their efforts to increase awareness of bystander CPR. One was an NFL player named Justin Reed, who is leading an effort. The other email said the Atlanta Falcons are teaming up with the AHA to equip players and coaches with the life-saving CPR skills during National CPR and AED Week. The second note is that Circ Outcomes published a paper recently from a group at Mid-America Heart finding that resuscitation practices for out-of-hospital cardiac arrest differ by geographies. Namely, compared to white catchment areas, communities serving Black and Hispanic areas have lower rates of out-of-hospital cardiac arrest survival. Now, of course, the causes of this could be a lot of things, but the research team noted that in Black and Hispanic areas, first responders were less likely to recognize cardiac arrest, police were less likely to respond to a cardiac arrest, and patients were less likely to be defibrillated. Basically, community-level out-of-hospital cardiac arrest care was less than what it is in white catchment areas, and this may explain the difference in survival. Perhaps. I think it explains some of the differences, but out-of-hospital cardiac arrest survival rates are complicated, and differences could also be due to the severity of the disease. My point in highlighting out-of-hospital cardiac care is that it's one of the highest value interventions in all of medicine. I spend many hours on this podcast discussing new treatments with marginal benefits. Bystander CPR and an adequate EMS system is hugely valuable. Why? Because only 10% of patients with out-of-hospital cardiac arrest in the U.S. survive. Ventricular fibrillation without CPR or an AED occurring out of the hospital is nearly 100% deadly. A patient with VF depends on the knowledge and availability of his or her neighbors. Since survival is so bad, any tick up is likely highly cost-effective. Plus, bystander CPR and public AEDs are nearly free of risk. It's all benefit. And look, I realize that cardiac arrest care isn't as exciting as the newest ablation catheter or stent or drug, but it's surely a lot higher in value than either of these things. A new tricuspid valve clip or more AEDs in your city? I'd go with the latter every time. So good on the AHA and the NFL. The other thing I love about promoting out-of-hospital cardiac arrest care is that it brings communities together for an obviously great and totally uncontroversial cause. All right, third topic today is post-stent antiplatelet therapy, and I hesitate to even delve into this topic because it is perhaps the most confusing in all of cardiology. But I will, because yet another study finds that less is more. Now, this seems too simple to state, but the idea is that having a metal cage propping open a coronary lesion is neither a fix nor is it free. Metal in the coronary attracts platelets and then clots can form. Stent thrombosis is a medicalized jargon word, but it's a terrible outcome because you go from a 0% blockage to a 100% blockage. The good news is that the body eventually and usually forms a layer around the stent protecting it from circulating platelets. This we call, and jargon-wise it is a whopper, endothelialization. The problem, of course, is that antiplatelet drugs, which prevent stent thrombosis, are also not free. Blocking platelets increases the risk of major bleeding in the gut, kidneys, and brain. So the quest, and it is surely a quest, is to find the Goldilocks recipe for preventing thrombotic or clotting events after a stent, such as MI, with the lowest rate of bleeding. Now, the usual regimen is to use 2 antiplatelet drugs like aspirin and either clopidogrel or ticagrelor or prasugrel for a period before switching to a single antiplatelet. Now, perhaps you can see the complexity already, right? So there's 4 antiplatelet drugs of varying intensity, and there are near infinite ways to break up the time after the stent: 1 month, 2 months, 3 months, 6 months, 12 months. There's different types of patients. There's ACS versus stable CAD patients. And then there's high bleeding risk and not high bleeding risk patients. And then there are different stents. And you start multiplying all these and you can get about a quadrillion different ways to do antiplatelet drugs after stents. Today I'll tell you about one trial, but know that there are many. The South Korean trial recently reported was called the 4D ACS trial. And it was a pretty clean trial. It was a comparison of 2 prasugrel-based strategies in about 650 patients who had PCI and stent during an acute coronary syndrome. One group gets 1 month of dual antiplatelet therapy with aspirin 100 and prasugrel 10, except the prasugrel dose is adjusted to 5 milligrams for older patients or patients less than 60 kilograms. Versus the control arm, which was 12 months of DAP with aspirin 100 and prasugrel 5. The primary endpoint is called NACE, not MACE, but NACE with an N, or net adverse clinical events. That's death, MI, stroke, ischemia-driven revascularization, and bleeding. Bleeding also has 5 different grades. The trial measures types 2 and 5, so the most minor bleeding was not included. And what they found was that short duration dual antiplatelet therapy is better. NACE occurred in 4.9% of the 1-month DAP group versus 8.8% of the 12-month DAP group. Now, the trial was a non-inferiority comparison, which is a good use of non-inferiority because the short duration is very much less intense than the standard 12-month DAP. If it was just as good, it would be a win. And indeed, 4.9 versus 8.8% easily made non-inferiority. In fact, the hazard ratio was 0.51, and that also made superiority. Now, why was this so? The driver of the lower NACE was a 77% lower rate of bleeding in the short duration DAPT arm, 1.2 versus 5.5%. There were almost no differences in thrombotic events such as MI, stroke, and ischemia-driven revascularization. I cover this study because it is such a clear result. If you're using prasugrel, a 1-month DAP regimen seems surely better than the 12-month DAP. So you would think it's clear now, but it's not clear. First of all these patients were Korean, and Asian patients may respond differently to antiplatelets than other groups. Second, the study used a type of stent that is not used in the U.S. Third, what about 1 month DAP versus 3 months of DAP? What about combos of different antiplatelets like clopidogrel, ticagrelor? In general, I can say that the trend of late is for shorter courses of DAP, but my solution in real life is to use one of the most important tools in all of medicine, and that is phone a friend. So I spend a lot of time calling my interventional cardiology colleagues and asking what they think. They've done the stent, and a bifurcation stent into ProxLAD is probably going to be different than a mid-circumflex lesion. And perhaps I can make 5 general statements about this, right? So ACS patients generally require longer DAPT due to higher thrombotic risk. Non-ACS patients most likely can safely use shorter DAPT durations. High bleeding risk patients may benefit from abbreviated DAP regardless of their presentation, and P2Y12 monotherapy after initial DAP shows some promise for reducing bleeding while maintaining efficacy. And, of course, an individual risk assessment may prove helpful in guiding duration and intensity of DAP. Finally, my friends, I've said this a million times, but if you're having a STEMI, you want a stent done fast. If you have chronic coronary disease, medical therapy first avoids the entire issue of deciding on the combination of antiplatelets. Sadly, this doesn't happen enough in many places in the U.S. All right, next topic, let's talk about lipoprotein a and the new PREVENT equation for predicting cardiac events. JAMA Cardiology has published an interesting study looking at the value or lack of value in adding lipoprotein a into the new PREVENT equation. Now, the first thing to say is that I covered the AHA's PREVENT equation in August of last year. The proponents of the PREVENT equation say it's better than the standard pooled cohort equation, which, of course, both of these output 10-year risks of atherosclerotic events based on clinical criteria. Now, of course, the proponents of PREVENT don't just say it's better, it has been validated in observational data sets. PREVENT differs from the pooled cohort equation because it incorporates kidney function, statin use, social determinants of health, and it removes the race category. It also starts at a younger age. Here's the most provocative aspect of PREVENT, and I find this interesting. It simultaneously is felt to be more accurate, so that's good, but it lowers estimates of CV risk and lowers the number of statin-eligible people. Well, I say gulp, double gulp. Anyways, the question of the JAMA Cardiology study was whether the PREVENT equation can be made better by adding lipoprotein a, which, as you probably know, is mostly genetically determined and when elevated is strongly associated with a higher risk of CV events. This is a reasonable question because since race is removed from PREVENT and race can bear on the likelihood of having elevated lipoprotein a, adding it could be important. So here's what the group did. It's a complicated study. There's two databases, the UK Biobank and MESA. This is, of course, a very big data paper. Both databases have long-term follow-up and lots of clinical characteristics. Individuals in the database were put into 4 categories. Low risk, that's 5% or less, 10 years. Borderline risk of 5 to 7.5% risk. Intermediate, which is a large category from 7.5 to 20% risk. And high risk greater than 20%. Then they measure 10-year event rates and they correlate it with lipoprotein levels overall and by risk category. And of course they do adjustments by age and sex. Their main endpoint is the net reclassification improvement, or NRI, which is a complicated endpoint. Let me try to explain. The NRI measures how well a new risk prediction model reclassifies people compared to an old model. But it does this by tracking movements in both directions and then netting them out. The NRI splits reclassification into events, people who actually had the outcome, and non-events, people who didn't. And for each group, it calculates the proportion who moved up in risk categories minus the proportion who moved down. This gives you a net movement figure for each group. Now, the problem with NRI comes in relative versus absolute differences. You've seen this in the NRI studies of CAC, for instance, where when you consider the absolute numbers, vastly more people don't have events and are actually misclassified using the NRI. Now, I asked Claude about this because Claude helps, and Claude came up with a conceptual trap that I think it's worth talking about. Claude says that people often interpret NRI as a 20% improvement in classification when it's really a 20% net improvement after accounting for movements in both directions. The absolute amount of reclassification, which tells you how much the models actually disagree, gets hidden in this netting process. So in the study, they measured NRI both categorically, that is, how many moved into a different risk category based on lipoprotein(a), for example, going from a borderline risk to an intermediate risk. And they also measured the NRI category free, which is simply whether the patient moved up or down in risk at all. And these differed a lot. In the category free net reclassification improvement for atherosclerotic events using lipoprotein(a) was about 0.06 or 6%. Now the categorical NRI was 10 times lower at 0.6%. Now the way I would translate this is to say that adding lipoprotein(a) reclassifies about 6% of people on net for CV risk, but it is far less valuable for moving people between low, borderline, intermediate, and high-risk categories. Here it was well less than 1%. Now, the study did something else that is perhaps somewhat useful. They looked at subgroups of people who may get more reclassification from lipoprotein(a). They found that adding the lipoprotein(a) measure resulted in slightly more reclassification for borderline risk and low-risk people. And that might be important because borderline risk people are trying to decide about statins, and there may be low-risk people who have an elevated lipoprotein(a) that might benefit from statins. But I have to say, when I looked at these absolute differences, they're modest. For instance, the NRI for low-risk coronary prediction was 10% versus 7.5% for intermediate risk. 10 versus 7.5% doesn't seem like a big difference. So overall, my comments, I feel like this is a nice paper. It's a nice effort. Adding lipoprotein(a) helps a little with prediction. A low-risk person, for instance, who has an elevated lipoprotein(a) may want to take statins. A borderline person with a super low lipoprotein(a) may want to pass. But here's the thing, and I feel it's the same with CAC. I've seen patients in clinic for nearly 30 years in the middle of America, and the vast majority of patients that I see, perhaps 90% or more, have no idea how to conceptualize the difference between a 7% and 9% and 13% risk of 10-year events. I've had lipids done recently, and I'm borderline risk, and I can't really conceptualize a 10-year risk of a non-fatal event. Now, maybe you can, but I can't. There's two reasons I struggle with this. One is philosophically. I'm almost convinced that much of disease and health is just good and bad luck, as in stuff happens. The second reason I struggle with a 10-year risk prediction is relative to Ukraine attacking Russia's planes and the threat of World War III. How much should I worry whether my non-fatal risk of a CV event is 7% without lipoprotein(a) or 9% with lipoprotein(a)? I come back to my bottom line when it comes to prevention. There are maximizers, and for these patients, they want to do everything. For them, you don't need lipoprotein(a). It seems useless because they're already going to take maximal statin and lipid-lowering therapy. And then there are minimizers who aren't taking pills no matter what. And for these patients, lipoprotein(a) is useless. So for the few in the middle who sweat the details, fine. You might benefit a little from adding lipoprotein(a) to the mix. All right, final topic today, sort of quickly, is atrial fib in HFpEF. Publishing in Europace, a group of prominent researchers, EP researchers, reanalyzed the TopCat Americas trial, looking at the role of AFib in predicting bad outcomes in patients with HFpEF. It's always worthwhile looking at TopCat. It's one of the most important trials in cardiology. Sadly, it was marred by data irregularities from Russia and Georgia. TopCat was spironolactone versus placebo in HFpEF, and the hazard ratio of the overall trial was 0.89 for the composite of death, cardiac arrest, or heart failure hospitalization. This 11% reduction did not reach statistical significance. But all-cause death was 22% in the Americas and only 8% in Russia and Georgia, and the drug had little effect in that region. And further, metabolic studies found that a third of patients supposedly randomized to spironolactone had undetectable metabolites. So, excluding Russia and Georgia, TopCat ended up being a positive trial with a hazard ratio of 0.82 and confidence interval 0.69 to 0.98. And I think this is a really important point because now with finerenone, we have spironolactone, and if you consider just the Americas part of TopCat, spironolactone is an effective HFpEF drug. So the Europace authors made two groups. They were interested in AFib. They studied patients who had AFib before or at study entry. This was called the any AFib group. And then they looked at study patients with ongoing AFib who had it at entry. Then they propensity matched patients with no AFib and looked at future outcomes in the trial. Now, I know it's pretty easy to predict what will happen. Before I tell you the results, I hope you are thinking small, hyperdynamic, non-compliant left ventricles are not going to do well losing the atrial kick when AFib occurs. So the primary outcome of this study was really comparisons in CV mortality. They had about 580 patients in TopCat who had any AFib, 400 who had ongoing AFib, and they found that any AFib was associated with a statistically higher level of CV hospitalization, heart failure hospitalization, and progression of heart failure. Any AFib, however, was not associated with an increased risk of sudden death. Ongoing AFib, similarly, was associated significantly with cardiovascular death, pump failure death, CV hospitalizations, and heart failure hospitalizations. And it was interesting to me, I think this is the most interesting finding from this paper, that neither any AFib or ongoing AFib was not strongly associated with sudden death. AFib seemed to associate mostly with progression of heart failure or pump failure. Now, this paper has a lot of complicated comparisons, but I think it can be summarized as AFib is a bad thing to have if you have underlying HFpEF. The question, of course, the clinical question is how to modify this problem with therapy. So my first recommendation when you have this is to phone a friend, your EP colleague. I can't give you a generic right answer because there isn't one in these patients. HFpEF patients often have serious comorbidities that have to be considered, things like polypharmacy and CKD and valvular heart disease and frailty. So maybe antiarrhythmic drugs are the right answer, maybe catheter ablation. And I think underused in many places is the pace and ablate strategy. We're going to see a lot more HFpEF these days because people live longer with more chronic illnesses. And when AFib occurs in these patients, it's serious. Take Mr. Rogers' advice and realize that we all need helpers in our lives. And please call your EP friends. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. Next week on Friday, I'm going to be speaking at the London Arrhythmia Summit, and I'm excited to be there. If you're there, please come up and say hello. And remember, if you like this podcast, please take the time, write us a review, or give us a rating. If you don't agree with anything I said, please email me or make a comment on the website. I learn a lot from this feedback. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.